Hello, everyone, and I hope you're having a great Saturday here in July. Welcome to the fifth annual Orbis Cybersight conference dedicated to Alan Crandall. I'm David Chang from Northern California, and I'll be moderating today. And just want to welcome all of the live audience from all over the world. Um, Alan Crandall, for those of you who may not have known of him or known him, was a real giant in anterior segment surgery, both in the fields of cataract and glaucoma surgery. He was a past president of ASCRS, but unlike so many great faculty and lecturers in anterior segment surgery, Alan was really also a giant in the field of global ophthalmology, and this was really his one of his passions. He's actually the only individual to have received the humanitarian award from both the AAO, ASCRS, and the American Glaucoma Society. And then finally, uh, I think those who were lucky enough to really know Alan know that he had a true passion for teaching. At the University of Utah, he had legendary sort of video sessions with the residents that became a model for other programs. And it's with that spirit of teaching in mind that we've established this annual conference dedicated to his name. I'm delighted to have an international faculty that we've gathered today, and you'll be hearing each of them present a case, but we really have structured this to have a lot of panel discussion throughout the day. So we have a former ASCRS President, Rich Hoffman, who's joining us from Oregon. We have a future incoming ASCRS President, Kathy McCabe, who is currently in Australia, although she's normally in Florida. We have a past APA CRS president and the current president of the International Intraocular Implant Club, Dr. Ron Yo, who's joining us from Singapore. And then we have Elena Barraquer, who is normally in Barcelona, but she's on a boat off of the coast of Italy right now. So I want to welcome all of them. And fittingly, many of our faculty themselves are quite involved in global ophthalmology and humanitarian work. Elena will be our first presenter. And in addition, Elena is the current awardee of the ASCRS Foundation's Chang Crandall Humanitarian Award for her career of incredible work in multiple countries around the world. And I thought we would just begin by having Elena tell us a little bit about her work. So good morning, good evening, Elena.
So the Elena Barraquer Foundation started his work in 2017, branching from the original Barraquer Foundation to do specifically cataract camps in especially Africa, but also in Latin America, the places where we have identified more need. It's a non-profit organization, and we work now. We have a team of more than 350 specialists, uh, surgeons, ophthalmologists, anesthetists, and nurses. And we travel to whatever country where we are needed. We stay there for approximately 1 week to 10 days, and taking with us all the material that we need to do these cataract camps, we perform an average of 400 phacoemulsification if possible. Sometimes we have to do extra caps or even intra caps for surgeon in those 5 days. How do we do it? Because we have a great team in Barcelona who organizes all these all these expeditions with taking care of the minimal detail, because in most of these countries and in most of the hospitals where we operate, they have no material whatsoever in case we forget something. We have gone to all of these countries that I'm showing in the screen, most of them, as you see, in Africa. We've done since 2017 83 outreaches with 190,000 people who have taken part. They have been beneficiaries of this in the world, in the way of having glasses or having cataract surgery or having a refraction or having treated whatever problem they had, if it was possible, the treatment. We have done more than 25,000 cataract surgeries. We have seen more than 250 people in consultation, given 75,000 glasses, and we have traveled 2,400,000 kilometers, taking 80,000, more than 80,000 kilos of medical supplies. We are very happy to do this work, and we wish and hope to be able to continue doing it for many years with many other specialists who will join us. And like this, I hope that even when I'm not able to do that, my foundation will continue doing this good work. Thank you. Okay.
Oh, wonderful, Elena, and congratulations again. And what an inspiring career you've had. I guess we have a video.
Yes. I'm going to talk about the cataract, the white cataract, and how to prevent the Argentinian flag sign. Most of you will know that in those type of cataracts, the most difficult part is the anterior capsulorhexis, because since the white cataract is usually intumescent, it tends to open up like it shows in this video. Even though we always have, we use trypan blue, I prefer vision blue because it's the one who stains the capsule more uniformly. But even if we try to decompress before, I mean, after opening the anterior chamber, usually it won't work. And even if when you think that your surgery is safe, the anterior capsule could open, showing the Argentinian flag sign and the difficulties that that can bring. This is a case that I did myself in Africa. That's why the video is not so good. And when it looked that it was coming all right, you see at 10 o'clock from my view, it opened up. So what I do in these cases is complete the rexis with the vitrectomy forceps or the disposable revolution forceps from Alcon, and I don't have any commercial interest. You can also do a previous capsulotomy with the jack laser, like is viewed in this slide, courtesy of Dr. Patricio Navarro from Argentina. This will also prevent successfully the Argentinian flag, or on this other video, courtesy of Dr. Gegundes from Madrid, Spain, you can do it with a femto laser. Both will be very helpful, but of course, some of us, when we travel, or many of you probably, won't have these possibilities. So the best option from my point of view is to do what is called a blancopunción, a white punction devised by Dr. Ariel Blanco, also from Argentina. You have to introduce a 30 gauge needle without opening first the anterior chamber and gently press down to empty some of the liquid in the capsular sac, after which you can continue the surgery as you normally do. And in most cases, I won't say that is foolproof, but in most cases, after doing this blancopunción or white puncture, the anterior capsulorhexis doesn't have any complication. This is another case. I already did the blancopunción. And as you can see, in this case, what I do is what you call like a staircase, round staircase capsulotomy, starting with a very small circumference and enlarging it as you see that the Argentinian flag is not appearing. Some of these cataracts are white in the outside, but very dark in the inside. So you have to be sure not to do a too small anterior capsulotomy, because that will bring other set of problems. But as you can see, the spiral case capsulotomy. And my point is, never underestimate a white cataract. Always use trypan blue to stain the anterior capsule. If you are going to milk the cataract, do it with the AC closed before you even have done a paracentesis. And if you have advanced technology, that may be useful. Thank you very much.
Wonderful cases and a great presentation, Elena. All right, well, you brought up a lot of different points, and this is, of course, something that everyone faces no matter where they are. We just throw it open to the panel to add some comments or discussion. Um, Kathy, I think I'll have you go first. Yeah.
All right, beautiful cases. I love the puncture before you open the eye, keeping everything very intact. A couple of things that I think sometimes help me. Sometimes preoperative mannitol can help, especially in intumescent lenses from diabetics. And more retentive viscoelastic like Helon 5 to make the anterior capsule a little more concave, if possible, can be something that's a little bit helpful. And then a high technology thing, I do often use femtosecond laser, but if it's very intumescent, you can still get an Argentinian flag. I have had that happen, but there's something called Zepto, which creates the capsulotomy in 0.4 seconds, and at the same time applies vacuum to decompress the capsular bag. And that can also be very helpful, but not readily accessible to everyone. But
that's the problem. That's the problem.
Yeah.
You know, I encounter most of these white cataracts when I travel to Africa, and we don't have either a YAG or a femto. So
yeah, yep.
Yeah. So
love that YAG video.
Ron?
Thank you.
You know, I think that was a brilliant set of videos, Elena. I think the only thing I might have done differently is when you put the needle into the lens, I would just highlight that it's important to aspirate almost as soon as you enter the capsule, just to decompress it immediately before it's got a chance to rip. And the other thing we learned from Sun Pek Chi is that once you've done that, there's still pockets of fluid in the periphery. And then we milk it by just using a cannula to just push the fluid towards the center. So you flatten that dome or the convex bits on the outside. And then that really is quite helpful in reducing the risk of the flag sign.
That's Ron, I'm at least your volume's a little low seeming to me. I don't know if there's anything you can do with your microphone or whether it needs to be closer.
I'll come closer and try and speak louder.
That helps. Yeah.
Okay, will do.
Yeah. So panelists, Elena, I think you used a 30 gauge needle. I believe I typically am using a 25, but what are the Rich, when you do the puncture, what's your technique and size needle?
Yeah, when I approach these, I try to do everything through a paracentesis. So I'll use a 25 gauge needle, stay in the capsule. One of the things I learned from Howard Fine was to go in bevel down rather than bevel up, so you can aspirate immediately. You don't have to worry about clearing the anterior capsule. As soon as you go in, you're aspirating. And I'll try to push down on the lens and decompress it. And when I start the capsulorhexis, I'm doing it with the micro-incision capsulorhexis forceps that Elena was using, but I'll do it through a 1 mm incision, so you don't have viscoelastic coming out of the eye like you would through a 2.5 or 3 mm incision. And before I do the puncture, I use a dispersive viscoelastic and I overinflate the anterior chamber again to get that concave pattern and push everything back. When you are aspirating, you have to be careful, because I have actually aspirated and pulled the needle out as I was aspirating and grabbed one of the leaflets of the capsule and created a trifurcation, which is as much fun to repair as an Argentinian flag sign. So you have to aspirate and then stop aspirating as you're pulling the needle out. But I do use 25 gauge.
Yeah, I use a 25. What about the syringe? I have been typically using a TB syringe, and then, it sort of fills up. And then I'm kind of left with, gee, I don't think I got enough out. So I have then tried to empty it and then go back in and learn that it's really hard to go in through the exact same puncture. And I often then end up with two punctures or a tear. Does anyone have a different syringe than a TB syringe?
Yeah,
Well,
I
typically
use it. Sorry.
Oh,
Go ahead.
let's see, Elena first.
I tried also a 2 cc syringe, because I repeat, most of the times I'm in Africa and I have what I can get. So I've tried 1 and 2 syringe, and it works also with a 2 cc syringe.
Yeah, that's what I do. I use a 2 cc
Mhm.
syringe, and I just aspirate them, and then I think the milking it's followed up by the milking, which I think is important.
yeah, I'll use a 3 cc just because we don't have 2 cc's very commonly available.
Yeah, I use a tuberculin TB syringe. I've never filled it up. So if anything, I'm trying to get fluid out, and it's not more than like 0.2 cc's.
Yeah. I think the other point you made, Elena, is you sort of start small because you have a little margin for error in terms of rescuing the tear if it starts going outward. And then you sort of seem to spiral, and I think that's a really
Exactly.
good technique. Does someone want to maybe describe Brian Little's maneuver, which I think is really helpful in these cases, because even though you open the capsule and all that cortical milk escapes, um, there's still cortex and liquefaction behind the nucleus, and that fluid hasn't escaped, so it tends to push the nucleus up. So even though you think, oh, I've decompressed everything and now this is going to behave, I have this beautifully stained capsule, it behaves a little bit like a normal eye, it tends to veer out. Ron, do you want to describe the Little maneuver just for the audience?
Sure. I mean, Brian Little taught us how to handle the runaway rhexis, basically. And when you see it running, the earlier you do it, the easier it is to pull it back in, of course. And then basically, I would lay the flap down. Often you need to put some OVD in just to get enough depth and control of the AC. Then lay the flap down, and I just basically pull backwards instead of forwards as we are normally doing. And when you pull it backwards, there's a bit of tension, but it almost always will really snap back into the intended path.
That's great. One question from the audience is ocular hypotensive agents prior to starting these cases. I think Kathy, you might have mentioned that. How many others in the panel do something like a mannitol in these cases? Does anyone else? Okay, Ron? Yeah. All
I
right.
do.
Yeah. So that's certainly something to try. I've not done that. And then one question was about the YAG capsulotomy. And so I know that was another case, Elena, but do you want to address if someone was to do that, the mechanics of that, how much time do you have? Can you do it in the office and then have a patient drive to the operating room, or does that create any issues in terms of when you get to the OR with IOP and that sort of a thing?
I have actually never done that because, as I said, most of my cases are in Africa and I don't have a JAG. That was a slide from my friend Dr. Hegundes, but he doesn't have the JAG in the operating room. So he had to do the JAG, a very small, just like one shot. And then, no, not sorry, it was not from Dr. Gegundes. It was from Dr. Navarro in Argentina. He has to do one shot and then take the patient to the operating room. But as I understand it, the time is not of importance once you have done that small. Of course, if it is the same day, the same morning, you cannot wait until the following day, because if not, all that material in the anterior chamber will produce an inflammation. But it's not a matter of seconds, near of minutes. You know, you can just bring the patient to the operating room.
I have
Yeah,
a
there's
I have a comment from Dr. Rossitelli with something I've never seen before, and that is attaching the needle to the phaco aspirating line instead of a syringe. So that's really clever.
it's a
Has
great
anyone ever
idea.
heard of that?
No.
No, but I was reading that too and thought, wow, that's pretty clever. And thank you for also giving us a reference where we can maybe see a video of that.
Yeah,
That's great.
that's fascinating. Uh, well, let's talk about you've done everything possible and yet it still tears out. What do you do at this point? So you've got a tear that goes from one edge of the lens to the other, the so-called Argentine flag sign. Um, Rich, do you want to kick that off? What's your next step at that point?
Yeah, I think Elena demonstrated that very well. You want to create a as much of a rexus as you can. So with two hemirexi, you use an intraocular microincision forceps or scissors and cut perpendicular to the tear on one side, tear it around, and then do the same thing on the other side. And then I would just start phacoing within the bag. I wouldn't do any hydrodissection, and I wouldn't try to rotate the lens if I could avoid it. And I've had a couple of these, and I've been able to get through them without having the tear extend posteriorly. That's the danger.
I had a lot of those because, you know, in Africa, sometimes 2 years ago in Botswana, they were all white cataracts. And I did more than 400 in those 5 days, and most of them were white. Not that I had Argentinian flags in all of them, but I had many of them that, despite all the precautions, as I said, I don't think that any of these techniques are foolproof. So, you
Yeah.
know.
So Ron, now you've got this linear coast to coast split, do you actually try to interrupt the rest of the capsule with a can opener or something to change the shape of the capsulotomy at that point?
Yeah, in general, I think I would, but what I would also do is have a good look, under the cortex and see how dense that nucleus is. Because if it's a large, hard nucleus, you're just going to need better access, and then I would do it. But and you never know what's inside a box of chocolates, just like you don't know what's inside a white cataract. And you might have something very soft and small. You might have a hard rock in there. So I think that would really modify the technique for the enlarging the rexus, really.
Yeah. All right. So if it's
But
a dense lens, which we're talking now really brunescent as they often are, I love that. So you would aspirate the milk, you get a sense of that, and you can kind of see it's awfully brown under there. Um, would anyone in the panel consider converting to a manual extra cap? And if so, kind of what would your technique be?
what
Yeah.
what I will do, what I will do will be to place the IOL first, because most of these cataracts won't have any cortex left. So I will place the IOL, and that will be like a protection against the posterior capsule. And then I will do the phaco.
Okay. Anyone else with a really large lens? I mean,
there's
yeah, go ahead, Kathy.
Yeah, just, I mean, you have to be very careful about what direction the split was in too. So you want to make sure that you're not, doing anything if you're splitting the lens or that's potentially causing that to extend posteriorly. So being very careful not to allow those forces to be in the wrong direction if you're phacoing still and trying to split the lens. So in a lot of ways, it may make sense to try to elevate the lens out of the bag so you're not putting forces on the anterior capsule and extending posteriorly.
Yeah. If it was a rock hard 4++ cataract, I would probably try to get it out of the bag and maybe use a loop and bisect it in the anterior chamber and then phaco it in the anterior chamber. But most of these are actually, the ones that I see are actually soft lenses. They're 55-year-olds, and there's not that much brunescence. I don't practice in Africa.
That's the problem. We have a kind of cataract with a name that we have invented, not too politically correct, but we call them Michael Jackson cataracts.
Yeah. I think with any type of interruption to the CCC, my pearls are if it's a reasonably soft to medium cataract, to try to chop it and then just lift the two heminuclei out into the anterior chamber. So what you're worried about, of course, is having this wrap around into the posterior capsule. And if at all possible, not to therefore rotate the lens, because rotating the nucleus is often the sort of most forceful maneuver we exert against the capsule, and that can create a wraparound. Has anyone seen a wraparound with an Argentinian flag? They don't happen that often, but I actually haven't had that happen. I wonder, is it because we have two basically points of weakness, so we don't have all the force sort of channeled into one? I'm just curious, has anyone had a wraparound from these cases?
No.
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 And a younger patient with a more elastic capsule too, it's often very stable, very strong. And, even a single piece of acrylic can be put in the bag, just 90 degrees to the tear, of course. So you have the most capsular support.
Great. Well, I know we're going to move on to the next presentation, but maybe one last thing. What do you do if these cases often have a really thick fibrotic capsule with sort of subcapsular fibrosis, make it even hard to start it? Do any of you have any tricks for that type of lens?
I've tried everything from the sclerotome to a cystitome to scissors, and one time that none of these would work, I used the cautery.
Wow.
I used the ORD cataracts, the small portable instrument, and it has an application for the cautery. And like that, I did a small hole. And then after, with the Revolution scissors, which have a very, very small blades, I did the capsulectomy.
Sometimes you do have to use intraocular scissors and microforceps so that you're holding it on tension.
Yeah.
In order to get the scissors to cut it. Yeah.
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 I just, if I could, David, there's a couple people in the chat who are in the question and answer who mentioned using phaco to start the rhexis, sort of doing that initial phaco energy on the capsule. And that works. I've never tried it. I think my heart would stop maybe, but people have, and it's very effective.
Mohan Rajan first presented that to us. He called it the punchorhexis. But like you, I would worry.
Yeah.
I have done it once, and it worked, but I think that it has the potential, again, if you are coming in tangential, unlike a needle, that you may get an eccentric tear, and it is kind of it is a stressful moment. Well, Elena, you can tell this was a really important topic, and I think we're going to move to another important topic, which also relates to the capsule in non-white lenses, and that's Ron Yo. And so Ron is going to pull up his presentation.
First of all, thanks very much. And I'm from Singapore, but I'm actually in Hong Kong now at another meeting. First of all, thanks, David, for having me, and thanks to the Crandall family for having me as part of this Cybersight, really to remember Alan Crandall's incredible teaching to all of us. So, David, you mentioned to me that you got residents in all levels of people attending this webinar. So I thought I'd really address a fairly basic topic, which is really preventing and managing anterior capsular tears. So let me just see if I can. Oh, no. Okay. So, PC ruptures get all the glamour. Very few people talk about the anterior capsule. Hang on, things are not moving. Let me just check that again. Okay. So, we all like to do our refractive cataract surgery and get perfect capsulorhexis. But here, let's watch some of the things that can happen. Here, I'm removing the cortex. And if you look at when I remove the side port cortex, you just get a glimpse that there's a radial tear just there. Okay, a small radial tear there. And as I'm finishing this, okay, we do what we know we should do, which is to inject some OVD in the eye so that your anterior chamber is maintained before you remove the instruments. And then when you put the OVD in, you can actually put whatever multifocal or toric lens in you can in general for all these cases. So let's try and move it on. And have a look at this other case now. You can see the radial tear to the left of the main incision quite easily there. And in this case, I'm just injecting air because I might not have enough OVD. And air also does the trick in maintaining the chamber. And as I finish off the cortical removal, you can see that that tear is there. And again, at this point, I will inject some OVD before putting the lens in. I'm trying to pause it, but somehow I can't seem to pause it. But I'm able to then inject a single piece IOL into the back. And I think we'll have the discussion at the end, David, because I can't seem to pause my presentation for some reason. And you can see here, this was a toric lens put in, and the lens is very stable. But now, so this is what they look like after you put the single piece lens with the IOCT on the right to show the position of the IOL in the bag. Now look at this case. This was a case that I did many years ago when I was a bit younger and more foolish and more impatient. And you can see that this is a much larger radial tear on the left. And as I was doing this, I was just telling my resident, oh, what you should be doing is injecting OVD before you take the IA tip out. But I've done this 100 times, and I've gotten away with it every time. And I was lazy that day, and I took a bit of a shortcut, and I said, I think we'll be fine. I'm just going to remove my instrument now. Just watch the capsulorhexis very carefully as I pull the instrument out. You see that? Okay, now you have seen me describe the pupil snap sign of hydrorupture. This I call actually, it's almost like a capsulorhexis CCC snap sign, because that radial tear actually extended way to the back that you couldn't even focus on it easily. But again, thankfully, most of these, when they extend posteriorly, you don't really disturb the hyaloid face very much, and I was still able to put a three-piece lens into the sulcus. And some of the points of discussion really whether we can put in single-piece lenses or should we be putting three-piece lenses, which is something we've learned from you, David, over the years. Now look at this other case, okay? Here, the end of the phaco. I've got radial tear on the left, as you can see. Okay, then we go on to the IA, and to my horror, as I remove this bit of cortex, I see that the radial tear has extended all the way around. The posterior extension is absolutely horrible, all the way across. there. And I'm going to turn on the IOCT here, and you can see in the lower of the IOCT pictures, the edges of the posterior capsule tear are scrolled up like into two round circles. And that's very interesting. And that's something I described during some of my movies on the use of the IOCT to determine PCRs. I now move the IOCT over to where the anterior radial tear is. And what's interesting is that the anterior capsule, you can see, is much thicker than the posterior capsule. And the posterior capsule rolls up like that because it's a lot thinner, whereas the anterior capsule doesn't. Now, again, with a case like this, some people might put in a single piece in the back. But in this case, I decided that it was safer to put a three-piece lens in the sulcus. Now, we can have a discussion again later on about whether we should capture this optic in the capsular rhexis, although remember, there is a radial tear present. Okay, so that's the patient that's got a wraparound, as we called it. So some of the consequences of anterior radial tears, of course, posterior extension, the IOL is less stable with tilt, induced astigmatism, and induced aberrations down the line. But it's worth thinking also, why do we get CCCH damage? Some of the time it's because we chop the capsule, or we might phaco the edge of the capsular rhexis, and actually torsional phaco is actually quite dangerous if you go near the capsular rhexis edge while you're removing OVD or cortex. And that's why we sometimes get little bites like this through the phaco tip, or this one where you see that huge scallop where there was a little sliver of torn capsule, which I just converted to this round scallop edge. So have a look at this tape. Now we can see here the capsular rhexis quite clearly, but when you start doing hydrodissection first on the right, you will see that once the fluid goes in, you can't see the capsular rhexis anymore. And we'll watch what happens when we do the hydrodissection to the left. And you can see that once the fluid goes in, we kind of tend to lose the red reflex and we lose our visibility of the capsular rhexis. Now, when that happens, and then I typically would inject some OVD to clear the cortex in front of the nucleus because I'm going to pre-chop this. So when the pre-chopper goes in, of course, as long as you keep it central, you're going to be fine. But if you watch my second pre-chop, I'm going to be rotating the nucleus around. When you're rotating, if you're not careful and you get too near the edge of the capsular rhexis, which you can't see, or this one, this chop, you see, I'm quite near the proximal edge of the capsular rhexis. You could quite easily tear the anterior capsule. So the point I'm making really is that the rhexis is not always visible during phaco. And if you look at this picture of a femtosecond laser capsular rhexis, it's round. It's also central in the pupil, but the pupil is eccentric. And if you look at this and you don't see this during your phaco, and your phaco tip goes straight in, you're much closer to the left edge of the capsular rhexis, and you might well tear it if you're careless. So I would always teach my students to have a mental picture of where the capsular rhexis was that you made, whether it's manual or with a femto, in terms of its location, size, and eccentricity. So you know roughly where your boundaries are in terms of chopping or grooving before you do a phacoemulsification. So the take-home point to any residents watching this is to really control the anterior chamber if there is an anterior radial tear to reduce the chance of a posterior extension. And just a few discussion points. When you have an anterior radial tear with or without a posterior extension, which IOL should we use? If it's just a radial tear, I think you can put a single piece in, but can you use a toric? And should we reverse optic capture? And if you're putting that three-piece lens, as you saw me put in the sulcus, should we do an optic capture in the capsular rhexis, bearing in mind that there's a radial tear? So I'm going to leave it there for you guys to have your opinions.
All right. Thank you very much, Ron. That was excellent. So let's start with the how to do the phaco first, and then we'll get to the IOL. These are really important questions that you posed. Let me just open it up to the panel if anyone wants to talk about. So the tear has gone out. We've been unable to rescue it. Do you hydrodissect? Do you rotate the nucleus? What are the next steps? Anybody?
Yeah, I think you have to be very careful about hydrodissecting and rotating and putting any additional stress on the area of weakness. But not all anterior capsular tears are the same. Some are small, some you can convert, and if that's possible, that's a great way to start it. But if it's already gone around, especially posteriorly at any point, or you can't really tell what the extent is, that's when I would be much more careful about hydrodissecting or rotating the lens for sure.
But most of the time, the hydrodissection's already been done, and it's really much later on when you see radial tear.
In those cases, I think I will try to put the nucleus in the anterior chamber with a lot of viscoelastic on top to protect the endothelium, to avoid working inside the bag and enlarging the tear and maybe having the nucleus fall in the vitreous.
Rich?
When I've created these, it's usually, I think it's from the phaco needle because it's always 180 degrees away from my incision. And so a lot of times I've gotten at least half of the lens out, so I just continue to phaco. And the only time I'm really being ultra careful is when I'm removing the cortex. So I'll remove all the cortex away from the tear, and then I'll do the cortex at the tear. And I'm very careful to pull the cortex towards the radial tear. If you pull away, you're more likely to get that thing to extend around. But for me personally, I think I do it with the phaco needle.
Oh.
Let me share with you just a weird way that this happened to me one time, just because it's a cautionary tale. And I'd been doing surgery, for 10 or 15 years. And I had a case where I did not connect the subincisional part where I start subincisionally of my manual capsulotomy. I didn't notice it. And there was a tiny little bridge left to the edge. And it caused an anterior capsular tear that actually went posteriorly as well. So I'm very intentional, make sure I go all the way and connect the two ends. It's a very strange case, but I've seen that I almost did it again since this happened. So just be very careful and intentional of that.
And another way I've done an anterior radial tear is when I reach in to dial a toric lens subincisionally, because it's hard to see it when you've got the infusion, the IA line infusing the anterior chamber, and I'm trying to rotate that toric lens, and I reached in and pranked the anterior capsule. So I mean, it can happen at any time. But thankfully, most times it's really after I've removed the nucleus or removed the cortex, or while I'm removing the cortex, that I notice the anterior radial tear.
I'm going to share my screen in just a case. Let's see if I can get this to play. So this is a tear right down here near the incision. I think what happened is they didn't connect. So I just try to horizontally chop in half, and then I'm mainly trying not to rotate the nucleus, because it's, in my experience, that is where you put pressure on the bag, as I mentioned, and then it wraps around. So I'm making these with the horizontal chopper. I can kind of come at different angles and create some sections. I could also just take two heminuclei out, but I'm just sort of doing everything I can not to rotate it. And then this is luckily a soft lens, and we can just pull these pieces out. And then at this point now, we have that single radial tear right toward the incision. And I think, and then Rohit Prakash from India has described something called the flat motility sign. And that is that if the flaps are moving, then you know you have not wrapped around. But here on is the toric, and because these haptics unfold so slowly, we're okay. And Dr. Prakash talks about once the little flaps stop moving, then it's probably wrapped around, and you may need to then convert.
David, you put the toric lens in this case. What if it was in alignment with the radial tear? Do you think you should still put a toric lens in that scenario?
Yeah, I think you have to be much more careful then, but in actual fact, you can. And it's I think if it was a low power like a T3, I wouldn't really worry about it. You can do a astigmatic keratotomy, touch it up. But it kind of brings to mind, what if you're trying to put in an EDOF or a trifocal? The toric is important. What if you had a high power toric? And the haptics, particularly on the Clarion Acrosoft platform, are really unfold slowly. There's no pressure on it. And in my experience, it'll release. And as long as you don't turn it, you'll be okay, and you won't wrap around. Anyone else in the panel want to comment?
Yeah, I was just going to say, like in those cases too, what I like to see is that the flap, the two edges of the tear, those flaps lay down nicely, and so you don't want it folded over or flapping up. You know, I like to see that they're sort of laid down in their right orientation. And then I don't know if anybody else does this, but I like to put myostat at the end, because I think the iris holding the flaps down maybe gives it a little bit more stability just as that fibrosis is happening postoperatively.
I do use also myostat or the equivalent when I have a capsulotomy that I'm not very happy with. So I agree with you.
I'm actually, since I have this here, I have this case, and this was just, I think someone asked about technique for trypan blue. So this is under an air bubble, but what happens with the air bubble is the meniscus will displace the dye from the surface of the anterior capsule. So what I'm doing is I lay the cannula on the surface and the dye will pull there. And then at that point, I'm getting more contact. So this is the case now that, let me see if I can get it to start here. All right. So as you see here, I'm starting the puncture, and this is a black lens. I've stained it, and right there you see that the tear has gone all the way across. And this is a case where I elected to convert. I saw a question: do you convert to a manual SICS, which you could, but in a case like this, I know I've got a big cataract, and I decided to do a traditional limbal incision just because I don't want any resistance to this coming out. And so this is just showing there's got to be that point at which, a manual extraction is just safer than trying to do this through
Yes.
phaco. So I just wanted to show that case there. Any other comments about, let's go to the lens. I mean, any other tips on the IOL when you have a radial extension? Ron specifically talked about a three-piece IOL and sulcus.
Yeah, and should we capture it or should we not because of the radial tear, I guess?
Yeah.
Yeah.
I mean, my tips are
single
you,
piece.
you certainly don't want to put a three-piece in the bag because, again, that's that pressure on the capsule. And if you try to rotate that, and in the old days, that's sometimes when you would trigger the wraparound. And I think that if you don't have I think a single piece is very safe, but you can certainly put in a three-piece in the sulcus. And I don't, if I have a big kind of half of the capsular rim still there, I'll sometimes tuck that in. I'm not sure it does that much to center it, but it's an excellent question. All right. Any other comments here? And I think those were all excellent points. And I think we covered the sign of the anterior capsule extension of the posterior capsule. Again, Dr. Prakash calls it the flap motility sign. And you're going to see this more when you're into the phaco section because now you've got irrigation aspiration, and as you start to remove some of the epinucleus and the cortex, you can actually start to see the edge of your rexus tear, and you just look to see if the flap is moving or shaking. That's a good sign because that won't happen if it has wrapped around. And how can I understand the sign of the anterocapsular rexus in the posterior capsule? So the extension, of course, is putting pressure on the bag, and it's just like on a bag of potato chips. Once there's a little cut there, and you start ripping it, it just violently extends. You have one weak spot that suddenly doesn't resist further tearing, and you really don't often know that it's extended until the nucleus starts to tip backward. So that's why you've got to be on hyper alert if you're going to continue phaco. And I think depending on your experience, there's no shame, and I think the panel would agree, in converting to a manual extra cap. I think many of the younger surgeons, at least in the United States, they don't know how to do a manual extra cap. We don't have the frequency of these ultra dense lenses, and so they phaco everything. And I think, as I just tried to show, a manual extra cap will be an acceptable outcome. But if if it's a smaller lens, I think don't rotate, and try to either bring the pieces up or chop it without rotating the nucleus. There is Charlie Kellman had a kind of a V trench that he popularized in the past, where you make, instead of a trench down the middle, you aim to one side and you make a little trench, and you aim to the other and make another, so you can actually crack the nucleus into three pieces rather than the heminuclei, and that might be an approach in that situation. Let's see if there are any other questions.
There was a question about putting a single piece in the sulcus. And of course, we don't want to do that because most are square edged and more likely to cause UGG or some chafing of the iris.
Yeah. If you're absolutely a great point. If you're going to do a lens in the sulcus, you want a three-piece, in part because there's posterior angulation of the optic from the haptics. Even then, you can get chafing. And so if you have availability of a round edge optic, such as the J&J AR40 Sensor, that might be a good choice. Rich, someone asked about should you put a CTR in if you have an extension in the anterior capsule?
I never do. I mean, I suppose you could do that using a Sinskey hook on the leading eyelid so you don't have any forces. But once you get it in the bag, then you've got these external forces that probably would cause it to tear out. So don't put a CTR in if you have an anterior field tear.
Agree.
You're on mute, Elena.
Why would you like to do that? I don't understand.
Just for the excitement.
Yeah, I don't think it would particularly be helpful. I mean, it's a good question. It comes up a lot, but this goes back to the theme of any pressure on the capsule of any kind.
Exactly.
That's when the wraparound tears.
Exactly.
And when you insert the CTR, there's a lot. When you rotate the CTR, there's pressure. So it's an emphatic no. That would be really a dangerous thing to do. But it's a good question. I'm glad someone asked that.
This is a case that I presented at David's cataract spotlight symposium at the Academy several years ago. It's a fairly routine case. 2+ nuclear sclerotic cataract, very routine. Last case of the morning, right before lunch. I do my cataract surgery still using a bimanual technique through 2 1mm incisions. I'm going to start the capsulorhexis, and the first part of this is fairly routine, so I'm just going to go ahead and speed up the video. I use a chopping technique within the protection of an epinuclear shell. And then once the endonucleus is removed, I remove the epinucleus and the cortex. I'm going to go ahead and slow it down now. Removing the epinucleus and then the cortex. And then I'm going to put a dispersive viscoelastic into the capsular bag. And hopefully everyone can see that the anterior capsule or capsule rexus is intact. There's no anterior tears, and the posterior capsule is intact. So I'm going to make a 2.2 millimeter temporal incision, and then I'm going to place a foldable acrylic lens in the bag. This lens has these little PMMA mittens on the end of the haptics. I'm going to put the lens in the bag and then center it. And you'll notice a crease in the posterior capsule. Those creases happen all the time from the forces of the haptic pushing against the bag equator. Does everyone see the crease in the upper left area right here? What's different about this crease is it doesn't go through the center of the optic like the creases we ordinarily see. It's off to the side. But you can get rid of these creases just by inflating the eye, pressurizing the eye, or pushing down on the lens. So I'm pushing down the lens, and the crease won't go away. This is the denial that I'm talking about. But the lens is in the bag, and it's centered, and it's lunchtime. So I figure I'm just going to go ahead and remove the viscoelastic and get out of the OR. I'm going to use bimanual INA hand pieces, and you'll see as I start to aspirate that I indeed do have some vitreous in the anterior chamber. And what you can't appreciate is the bag is not 100% stable, but it is centered. So this would be a good point to ask the panelists what they would do. From my perspective, the three options were to leave it alone because it's centered. The second option is to perform an IOL exchange with a three-piece IOL placed in the sulcus with optic capture. And the third option is reverse optic capture of this lens, leaving it in the eye. Any comments?
Elena, did you want to?
Okay, unmute. I will always remember a phrase that says, best is the enemy of good. So but personally, I will leave it alone if it is center. And if there is a bit of vitreous in the anterior chamber, I will do all the style vitrectomy with a sponge and scissors, and that's it.
Mm-hmm. No, I mean, I think if it's a monofocal and it's centered, you could just address the vitreous. I would personally use a vitrector through the limbus with a separate side port infusion because if it does decenter, you can simply go back at that point, but you could at least give it a try. If it was decentering at this point, then I think you don't want to put the single piece in the sulcus as we just said. So I think at that point, removing this and putting a three-piece in the sulcus and then doing your vitrectomy, would make sense. Are we thinking, Rich, that the capsule? I mean, I think at this point the surgeon has to be thinking, okay, this is a surprise. The wrinkle is more than just a wrinkle in the capsule, it's a rent. And you kind of want to be thinking, well, how did it happen? Because that kind of is your insight into the anatomy that you have to deal with. And so I've certainly had it happen where the bag either isn't inflated enough or it deflates with some burping out of viscoelastic. And you certainly can puncture the posterior capsule with the edge of the IOL as it's being injected. And these are such routine cases, and we're just sort of quickly shooting the lens into the eye, and it can happen before you know it. And so, is that your thinking here in terms of what the etiology is?
My thinking was that the haptic and possibly those PMMA mittens on the tip, which appear to have a fairly sharp edge, in my opinion. But I think probably the haptic might have torn it. And what you can't appreciate in this picture is that the lens really isn't that stable. And I'm sure if I just left it there, my experience has been when you come back the next day, the lens is markedly decentered. So I didn't feel comfortable just leaving it there. And there's a little bit of a tilt to the lens. It's not
Yep.
quite like diving back, but it's almost ready to do that.
Yep. Well, so that's the point. If you're, and this again, as a surgeon, you sort of have to stop and take a deep breath and why did that happen? This is not just a random bad luck things. And if your conclusion is, gosh, the chamber was a little shallow, and the cornea is a little wrinkled as you're doing this, you don't have a good view, and that I must have injected the lens into the capsule such that it punctured it, then leaving it is a problem because you've actually punctured the area that's supposed to support the haptic. And that is your clue at the time that maybe leaving it alone, even without the signs that you mentioned, is pretty precarious, which means you could try to walk the lens, not so much rotate it, but reposition it and sort of slightly rotate it by walking it along. Or if it's really tilted, as you've said, I think at this point, you're better off taking it out. Reverse optic capture is a great option if you really need the single piece in there because you had a trifocal or a high-powered toric, and you just really want to give that a try. But if it's a straight monofocal, it may be easier for many people rather than reverse optic capture to just extract the lens and then do your cleanup with a vitrector and then put a three-piece in the sulcus. Any other, Elena, did you have any other comments? No. Okay. All right, Rich. So,
yeah, my thought was to try reverse optic capture. When you're in the heat of the moment, I don't want to say you panic, but you just try to react very quickly. And so I thought I would do reverse optic capture. If I couldn't get that to look good, then I would do an IOL exchange. And I injected a little bit of dispersive viscoelastic in the anterior chamber, and then I went behind the IOL and injected a whole lot more, hoping to push the vitreous back through that opening. And with the viscoelastic cannula, I was able to very easily prolapse the optic up in front of the rexus, leaving the haptics in the bag. And then I went ahead and decided to remove the viscoelastic with a vitrector, using a bimanual technique. Unfortunately, the vitrector wasn't the same gauge as the incision, which is not ideal because you can see the BSS coming out of the incision. But this is what I had at the time. So I'm removing the viscoelastic, and I really don't see any vitreous in the anterior chamber any time during this bimanual vitrectomy. And I confirm it by staining the anterior chamber with non-preserved triamcinolone, keeping the irrigator in the eye, and washing it out with the irrigation. And there's no vitreous in the anterior chamber, so I was somehow able to push the vitreous back just by putting that dispersive viscoelastic behind the lens. And at this time, I feel like I'm home free. There's still a little bit of OVD in the anterior chamber, but I'm just going to stromally hydrate all of the incisions, hydrate the main incision, and then remove the irrigator and hydrate that final bimanual incision. And I like to inject myostat mainly to hide the nasty deed that I've committed, and also to confirm that there's no vitreous strands to any of the incisions. So the pupil does constrict concentrically, confirming that there's no vitreous. And it's always a good idea to tap the eye a few times for luck at the end of the case. So this is the patient a week after surgery. You can see the optic is well centered, it's stable. This is an OCT image showing the anterior surface of the optic, which again is in front of the capsular bag. And there's a very nice clearance between the IOL optic and the posterior surface of the iris. It's been mentioned several times this morning that you should never place a single piece lens in the ciliary sulcus. The haptic of these lenses and the optic will chafe the posterior surface of the iris, causing pigment dispersion and glaucoma and uveitis. And I've seen several cases of recurrent hemorrhages from these lenses in the ciliary sulcus. However, placing the lens in the bag with reverse optic capture is an option. This study by Jones and Oding looked at 16 eyes with reverse optic capture, and they found 94% of them were 20/25 or better. 94% had plus or minus a diopter from the intended correction, and all of the IOLs remained centered, and there were no vision-threatening complications with almost 2 years of follow-up. And what they concluded, and what I agree with, is that reverse optic capture of a single piece acrylic IOL through an anterior capsule rhexis merits consideration for IOL placement and most importantly, probably IOL rescue in selected cases where the IOL is in the bag and there is insufficient posterior capsule support.
All right. Thank you, Rich. Any comments? Kathy, or if you're back, we're just talking about a reverse optic capture. Any tips for that?
Yeah, I mean, I think it's very useful when you have the need to put a single piece acrylic in, and definitely used it there when we don't want to leave the entire IOL in the sulcus. You always do have to be worried that there can be some chafing even at the edge of the optic. So you don't want to do it in a too crowded an eye. But I find that to be quite useful for a posterior capsular tear that you can't convert to a nice round posterior capsulotomy.
Yeah. It's a wonderful technique that I think probably Howard Gimbel maybe was one of the first to innovate this, and the tech the setting that Rich showed where the lens is already in there, and you might be able to then salvage fixation of it, and then what we were saying earlier with the if you have a toric. You have a multifocal, trifocal, and you want to, still attempt that. It certainly works. The rhexis diameter has to be just right. If it's too big, you won't be able to capture it. If it's too small, you're just going to struggle, and not achieve it. And then, of course, it has to be centered because that is going to determine everything. I have, because this is such an important topic, I have a couple of cases here on phaco with zonulopathy. And let's see, we have 15 minutes. So, one of the points that I would make is that this is what we want to avoid, this capsula phimosis. And so this occurs with diffuse zonulopathy because you don't have the centrifugal resistance to the contracture of the rhexis. So the key is to secondarily enlarge the rhexis if you need to, or to basically make a little relaxing cut in there. And then I'm just going to go back to this point and show this case here. This is a case where I aspirated the anterior capsule, and I thought, well, let's put in a CTR. And what you'll see is all of a sudden, as that goes in, look at the force exerted on the capsule. We've got about 4 clock hours, well, maybe more like 5. We got a huge zonular dialysis. And so as I start to extract the cortex, you see in this older video that the entire bag is moving. And so now the CTR has done more harm than it's done good because it's basically placing all these cortical stripping forces and applying it to all of the zonules. So a CTR makes sense when most of the zonules are healthy, but it's a bad idea when most of the zonules are missing. And so this again was a case where when the zonules are that weak, we often momentarily aspirate the anterior capsule with our cortical stripping, and in this case, that was enough to cause a dehiscence. So this makes the point that when you have diffuse zonulopathy, rather than a CTR, capsule retractors are the best way to sort of give yourself artificial zonules. They support the lens in the AP direction. They keep the peripheral bag from being aspirated by the phaco tip, and they'll basically give you counterfixation for things such as rotating the nucleus following hydrodissection. So there are many different ones in the market. These are from microsurgical technologies. They're double-stranded. And so here I've actually placed them in before I rotate the nucleus so that they serve as my artificial zonules. You just have to be careful, unlike we're used to with iris retractors, cinching them up so that they retract the pupil. And here the retractors are supporting the bag. We don't want to stretch the rexus because it's not as elastic as the pupil, and it can tear just from that. So you sort of have to be very careful that they're not stretching things too much. And then here I'm just using a horizontal chop. Now, one of the signs with weak zonules is as you insert the CTR, look at it bend. You see how the whole ring is bending. And so you have to stop at that point. This is a traumatic cataract with a dialysis in the nasal quadrant. So now I'm sort of putting in more viscoelastic, and this time I'm hooking the eyelet to get past those not only the zonula dialysis, but those retractors. And then once I'm there, I can pull these out, and then we're okay. I'm a big proponent of, in these cases of diffuse zonulopathy, when you're doing otherwise a monofocal, of putting in a three-piece in the sulcus. And in this case, because the lens in the sulcus could rotate through the nasal traumatic zonular dialysis, we want to capture the optic. And I call this sort of belt and suspenders. So you've got the bag, but by putting the haptics in the sulcus, you're getting another 2 points of fixation where the ciliary body is supporting the haptics as well. Um, Now, this is the typical problem I was showing earlier, which is just the CTR itself tends to displace the bag. And here, look at the entire fornix is there, and I've quickly got to stop. And this was a case of actually a dead bag syndrome. So Dr. Shimawaki has developed from Japan this spiral CTR injector that you can see is available from Katina and from Corza. And it's a very clever thing because in addition to the normal hook that is retracted, there's a fixed hook that grabs the front eyelet. And as you can see, as I inject, the injector hook, the second hook, is already basically taking all of that force of the CTR injection, and I'm not therefore having to put the force onto the capsular bag. So in a case like I just showed, where there's all this other hardware there with the capsule retractors, we can maneuver around that. And so the eyelet doesn't have to run along the capsular fornix to get in there. And sometimes if you have trouble disengaging, you just use a second hook to knock this off. So I have no financial interest in that. And then final point here is this is the last piece. It's dense, and I know I've got to protect it. And right there at the end, I'll show that moment just again. I know the capsule's right behind there, and I just move my chopper just a little bit, and that's enough to snag the capsule. And you can see here that created this small puncture here. So the point of this is you've got to realize that you don't have normal zonular stretch to the capsule. And so the capsule is not taut like a taut sail and wants to fly up to the phaco tip. So what I should have done is what I'm doing here before getting that last piece, putting in a dispersive viscoelastic into the capsular bag. Dispersive because it doesn't get aspirated and it's basically stretching the capsular bag. It's not just pushing it back, it's actually putting the posterior capsule on stretch. So here's that case where, again, we've got weak zonules. You see the capsule retractors. So use that dispersive. And now, because the posterior capsule is on stretch, as though the zonules were normal, it stays away. This is the same case. And with zonulopathy, you see the posterior capsule doesn't want to separate from the cortex. And you see all the folds in the posterior capsule. It's kind of coming right up to the INA tip. And this is, where you have to be so careful to not aspirate the posterior capsule. What it really points to is lack of zonular stretch, diffuse. So instead, now I put in my dispersive viscoelastic, it happens to be viscoat, in the same case, and now you see how the cortex separates because the dispersive put the posterior capsule on stretch. So dispersive viscoelastic, is a great tip right there. So a couple of points that I just wanted to make there are use capsule retractors, reinflate the bag with dispersive OVD. A small rexus is fine because you're just trying to get the rexus completed. That allows you to, it's critical because it allows you to use capsule retractors and later a CTR used by manual INA if you need to. Delay the CTR until as late as possible so that you're not trapping cortex. Use a spiral CTR injector if you have one available, and then a three-piece in the sulcus. Let me just stop there. And Kathy, I'm so sorry we couldn't show your video, but I know your connection is not that good. Any comments from the panel just on zonulopathy in this topic?
Yeah.
Go ahead,
Go ahead,
Just
Elaine.
a quick comment while I'm here before I disappear again. I just, and I apologize, I didn't get to see everything you showed, David, but using a second instrument through the eyelet, Sinski is something that I often will do. I think you were showing where it can get hung up and maybe that new device for helping with that. So pretty much anytime I think there's zonulopathy enough to need a CTR, I'm using a Sinski through the paracentesis to engage the leading eyelet. And the case that I was starting to show was about putting a three-piece in the sulcus after the CTR is placed in the bag and then doing optic capture, and how that can be kind of a low-tech, long-term solution for diffuse zonulopathy and how stable that is. So, and not sure if you were able to mention that.
Very good point. Yeah. Rich? Oh, sorry. Go ahead, Elaine.
I agree with you and with Kathy because usually, the idea is that if the bag weighs more, has more chances to all fall into the vitreous. So if you place that's what I do too. When I had to put a capsular ring, I put the IOL, the three-piece IOL in the sulcus in the hopes that if in the future the bag falls down, the lens will stay in the sulcus. And since, again, most of these cases, I'll do them in Africa, where most of the patients don't have any follow-up. So that will help to preserve the lens in its place.
Absolutely.
Great. No.
Just
Rich?
couple of comments about CTR injection. If you have a localized area of a zonular dialysis, you should inject the CTR so that it's directed towards that area, not away, because you'll make the zonular dialysis worse. And if you have a diffuse zonulopathy, I use the hook or Sinski hook in the leading eyelet, but I find it very awkward. I'm right-handed. I find it very awkward to do that and inject the CTR to the right. And so what I found is very helpful is to inject the CTR to the left if you're right-handed and have the hook going through the left-sided paracentesis. And that way you don't have to deal with the injector getting in your way. And if you're injecting with the Sinskey hook, you're really not creating any stresses on a particular area. So you don't have to worry about injecting it right or left because of the diffuse zonulopathy. And using a Sinskey hook basically allows you to inject the whole thing and release it without putting any tension on the bag equator. So right-handed, inject to the left. If you're left-handed, inject to the right and put the hook through the paracentesis on the right.
Very good points. Two questions from the audience. One is, can you prevent anterior capsular phimosis in these cases by doing reverse optic capture? And we're talking about, I showed that severe phimosis in the beginning.
I mean, I think anything that
yeah,
kind of maintains the edge of the capsule, potentially can help with that. But also the other thing I would suggest is you want to be gentle, but at the same time, consider trying to get as much cortex out as you can, making sure that if you can polish maybe a little bit of the underside of the anterior capsule when you leave these cases as well. There are some bag in the lens techniques, especially with some newer designs of IOLs that may be helpful as well in preventing that anterior capsular phimosis in these cases.
Yeah. I think reverse optic capture is really, really tough if you've got zonulopathy, because the anterior capsule isn't as taut. So I'd be very, very careful about that because you might cause a dialysis. And I think if you're not comfortable, I think the main point I was trying to make is don't leave it small because it's almost like a sphincter and the zonules are not going to resist the contracture. So if you're not comfortable with sort of making an oblique cut and re-tearing a slightly larger diameter, which is much safer to do when the IOL is in place, it's not difficult. But you could also make just some little relaxing cuts, partial, not all the way out to the equator, in the anterior capsule. Think of it like a sphincterotomy. And I think that's better than reverse optic capture. And then the last question was, if we got a zonular dialysis, can I put a three-piece IOL in the bag and have the haptics face the area of the zonular weakness, which I think makes sense. But panelists, would you agree that if you have a CTR available, that maybe that is the best way, depending on the situation with the zonular dialysis?
Yeah, I
would
think
do
the two
both.
strategies, together, exactly same as Ron.
Yeah. So in other words, you would put a CTR in, and if you have a three-piece lens, aim it toward the area of weakness. Okay.
Yes. And if you want to put it in the bag, I think it's better to use a one piece, which will unfold more slowly and will put less pressure in the already weak bag. So if I put a three piece, I'll place it in the sulcus. If I want to put it in the bag, I will put a one piece.
So I agree with that, and I think I showed that on that one traumatic case. I think a three-piece and the sulcus is again, I call it built-in suspenders, but they're capturing the optic does do a lot of things. You have to be careful. You first have to aspirate some of the viscoelastic out of the bag because normally we put the three-piece with optic capture when there's PCR and the viscoelastic drifts into the vitreous space. But if you have an intact bag and you're doing sulcus placement with optic capture, you will capture all the viscoelastic in the bag, and that'll distend the bag, push the optic forward with a myopic surprise. So you sort of aspirate a little bit out, and then you capture the optic, and it will prevent CCC contracture. It'll prevent rotation of the lens. In that case, I didn't want the haptic to rotate through the zonular dialysis. And you actually don't have to, it'll help center the lens, and you don't have to change the IOL power. So I think we're at the end of our 90 minutes. This is all going to be recorded because a lot of the audience will watch this not live, but virtually later. And of course, anyone in the live audience can do this. It's archived on the Cybersight website. And please tell your colleagues if you thought this was useful. This is always such fun to gather, cataract faculty from around the world to kind of have an unscripted discussion. I thought this year our panelists were just fantastic, and I want to thank all of them for joining as well as presenting some really excellent cases. And finally, a big thanks to the Cybersight team. They do such a great job on putting education on for a global audience, and this is no exception. And again, we're all so proud to do this in memory of and in honor of our colleague and friend and inspirational mentor, Alan Crandall. So with that, I'm going to say on behalf of all of the faculty, good night, good morning, and goodbye to everyone. Have a good weekend.
Thank you.
Yeah,
Bye-bye.
thank you.